Hey everyone, welcome to conference today. Can somebody who's online just let me know that they can hear me?
We can hear you.
Perfect, thanks Dan. Okay, so we have another clinical reasoning conference, and I wanted to set this conference up today because if you've ever had an attending or somebody show up like last minute, ask the exact right question to the patient and crack the case, and you wonder how were they able to do that, they're likely utilizing some of the techniques we're going to be working on today. And so let's get started. So the conference today is in the style of one of these things is not like the other, and so it's going to be up to you to tell me what. And I like this picture particularly because we always talk about how there are zebras in medicine. That's not the case today, but it was cute. Okay, so this is sort of along the lines of the conference that we did last week that's available for y'all on our YouTube channel, where we compared two very similar patients with abdominal pain and then how it was that we arrived at a different diagnosis for both of them. And so we're going to sort of continue that theme today. So your task is simple, it's to pick the odd thing out. And our objectives for today are to exercise some type 2 thinking by choosing what doesn't belong. We're going to practice a few board questions. And then I want you to challenge me if you see a different way that something else doesn't belong, because both on the boards and in conferences, we want you guys to feel comfortable to call us out if we say something incorrectly or ask the question why, which has now become one of my favorite questions to ask in medicine. So please challenge me if you think that I'm presenting something that you see differently.
What is type 2 thinking?
Yeah, so there's type 1 thinking and type 2 thinking. Type 1 thinking are the heuristics, which means that sort of rapid thinking, and these are patterns that we've developed in our brain. So these are sort of almost automatic things you think about. Someone comes in with chest pain, you are going to immediately ask them where, what made it worse, what made it better, and you're already getting to an MI. Type 2 thinking, taking a step back, wondering, well, could this be pericarditis? Could this be myocarditis from a Zika virus infection they had? And so it's really slowing down and asking more questions to keep your differential broad. So it's just that slower type of thinking. We don't do it often, and we have to actively put ourselves in the mode of type 2 thinking. All right. So how could I not begin with an echo challenge? So here are 4 echo images. And if you want to come up and take a look at them up close, our folks online can see them. And so when you feel ready, tell me which one of these doesn't belong. You can talk amongst yourselves, each other out, say what you're seeing.
I think 4 doesn't have a pericardial effusion, right? The other ones do. Sneha, are these all the same view? Parasternal long?
Yeah, these are all the same view. These are a parasternal long view, so identical views. And this is meant to take some time, right? Because we're doing that slow kind of thinking. We have to evaluate it up close. Please chat your answer if you think you know. With an explanation would be great, too.
I think you're right.
Okay. Somebody thinks it's 4 because maybe that one doesn't have a pericardial effusion. Any other guesses?
I go with 2.
Okay, Peter's going to go with 2. Peter, tell me why you think it might be 2.
Also more hypertrophy and thick than the other ones.
Okay, that's not bad. So you're, okay, so Peter's word, we can talk about that. That wasn't what I was going for, but you're right. That one does have the thickest wall of them all. Okay, let's go through this step by step and see how I arrived at the answer, and then Of course, you can point out other things that you may see. We have some attendings on the call who can point out if there's something I missed. So I think I heard murmurs about the fact that all of these seem to have a pericardial effusion, and maybe the question is the number 4 doesn't. But in fact, all of them do have a pericardial effusion. And so can somebody point out where the pericardial effusion is?
So like in 3, it's like pretty big.
Yeah, is it here, Anita?
No, it's
No.
not on the area. Yeah, okay, no, that's true.
Okay, so this is the pericardial effusion, right? This is the thick ventricular wall. And then here, there shouldn't be anything. It should just be more soft tissue, part of your lung. And so this fluid is abnormal. It appears in image 1. It appears in image 2, in 3, and in 4. There's a very small pericardial effusion also in 4. Okay, Peter, good job with the wall. That is the most different than number 2, but there's something else, I'll give you a clue, that is in picture 1 that isn't in any of the other ones.
I have a medical student guess,
Yes, please, medical student guess.
a VSD.
A VSD. That it may be there is not what I'm going for, nor can I actually tell this on this type of echo. Very rarely would I look for one on my own. I think that would have to be a more formal echo. Okay.
Do they have,
Need Doppler. Yeah, Dr. Happy says for VSD you also need a Doppler.
like 1, is it, I feel like the valve is a little weird. I don't know.
The valves are fine. We can't see
Okay.
them moving, so we won't know exactly.
You can see the coronary sinus kind of in one,
You can see the corner, this thing?
a little bit to the right of it.
This thing?
A little circle.
Yeah,
right just-
sure. That's a good catch. Okay, anybody, any of the attending?
We've given up.
No, I just want to give whoever, if somebody knows the answer, a chance to give it away here before I tell you.
Is it
Okay, so-
the outflow tract looks a little bit different to me? I don't know. I could
No,
just be like,
Yeah, that's not it, Dan. Okay, so let's talk about what the difference is between number 1 and the rest of them. What we're focusing on here is large black area back here. And why is that area so much blacker than all of these other images? Anybody? Nope.
Yeah, pleural effusion.
Pleural effusion. So remember, fluid is black in ultrasound, right? Blood inside these chambers is black, this fluid is black, and so why is this area more black? And so when we compare images 1 and 3 against each other, you'll notice here that both of them have this pericardial effusion, and there is a way you can tell whether something's a pericardial effusion or a pleural effusion. And what you're going to look for is this rat tail appearance in comparison to the descending aorta. And so if you guys can see, in most of these images, we're seeing this black spot, which is the descending aorta. And pericardial effusions are on, I guess, on like top of it, superior to it when you're looking at parasternal long view. And so all of these have this rat tail appearance that goes superiorly to the descending aorta. And so that's how I know that these are all pericardial effusions. So then, in this image, you also see this large black area that's sort of below the descending aorta, and you will catch this on patients that have large pleural effusions as well. And so the way this image is different is that in number 1, we're also seeing a pretty large pleural effusion. But Peter, great catch with the thick wall. That was a good one too. What questions do you have about this? Okay. So just sort of what I described, here's the descending aorta. You want to see this rat tail appearance of the pericardial effusion. Anything that's dark and black beyond it will be pleural effusion. All right, so we said we would do some questions. I'm going to let you all read this question to yourselves, and then tell me what you think the next best step in management is. When you think you know it, just shout it out. Type it in the chat.
All cards.
Call cards. Cards is like, yeah, thanks for calling. What's your question? What do you want me to do?
Pericardial.
Pericardial effusion. Wonderful. Thank you, Dr. Kasari. That is the correct answer. Through all of this crud, it turns out the patient's hypotensive, has distant heart sounds. Ultimately, echocardiographic findings are consistent with a cardiac tamponade. And so, as Danny taught us in his conference earlier this week, pericardial effusions, if large enough and accumulate quickly enough, can cause tamponade, and the patient needs pericardiocentesis. If it reaccumulates, they can also put in a window that's sort of more semi-permanently constraining that area. So watch that conference, it was excellent. All right, on to number 2. 5 viruses. Tell me which one doesn't belong or is different than the rest.
It's been a minute since we've heard about Zika virus.
It's been a minute. Anita, you mentioned Zika. Which one do you think is Zika?
5?
5, yeah, great, okay. It would be helpful, this is an interactive conference, so it would be helpful if y'all talk to each other. And like Anita said, virus 5, she thinks it's Zika, what you think the other ones are. And
COVID.
Who's COVID, yep.
One is probably BCV, or is maybe a hepatitis.
Yep,
3 is
or-
a picture of a mosquito. There's a lot of things. I think it's a mosquito. West Nile.
Yes, it's West Nile. Okay, so I think I've heard all the right ones. So virus 1 is a herpes virus in general. 2 is COVID. Not COVID, SARS-CoV-2. 3 is West Nile. 4 is Hep C, and 5 is Zika. You still need to tell me what connects 4 of them.
Are they RNA viruses?
I was like, sorry, Anna. Yeah. Okay, so this is a little bit different, right? So you can think about ways of, okay, what part of the body do these infect? Well, they're all kind of different, and some match, some don't. What's their transmission vector, or how are they transmitted amongst people? Those are all different amongst these. And so the thing we're looking for here, and we don't think about often, is really like the basics of the organisms with which we're dealing, right? It matters that Listeria has a flagellum with which it can float around inside cells. And so with these viruses, herpes viruses are DNA viruses, the rest are all RNA virus. And I care less about that and more about sort of just knowing that when you're thinking about diseases, sometimes just taking a step back or going back to the pathophysiology or really like digging deep of why something is happening is important. And so just a question that sort of relates to these viruses. This is off the board. This is a tough one because we don't deal with Zika that often. That used to be the scary one. It used to be the scary one, yeah.
I know.
Before it was Ebola, right? We've dealt with a lot of viruses lately.
Wait, what's the question? Like what viruses?
The question is, what's next test you want to do today?
Oh, okay.
Yeah. Anybody, just shout it out.
Maybe D.
It can be a guess. Okay, so somebody said D. Any other takers?
B.
I'd say,
B. Okay. Ariana?
I would say D.
D? Okay, great. So a lot of people said either B or D. Peter, I also thought the answer was B, which it is not. Nor is it D. The correct answer here is C, doing the antibody test. And so you don't have to know this much detail about Zika virus, but the point here is that Zika virus has a quick inoculation period. And so you'll get it within 2 weeks of exposure, and then from that time, your body will start developing antibodies, and so beyond 2 weeks of exposure, doing the RNA test will not yield the virus in the blood. It's already been cleared by your body with antibodies. And so with this patient who had exposure 4 weeks ago, the RNA PCR will not yield a good result. And then she first needs to get diagnosed with Zika in order for us to start the ultrasonography. And so we have to make the diagnosis of Zika in her first, which we do by getting the antibody test. And then if she does have Zika or had it, then we need to start doing this ultrasonography because Zika can cause microencephaly in newborns. Okay.
Is there a reason IgM instead of IgG? Like, is there a period where you would start testing for the IgG instead of the IgM?
Yeah, I think
IgM made first, right?
IgM is made first, so it's really, it sort of depends. I think
it's like after like a couple months.
it's gonna be
then your
pretty
IgG.
varied, and the problem here is that we really wanna figure out whether she had Zika or not because of the baby. And so if IgG doesn't develop, say, like 6 or 7 months into her pregnancy, then it's too late for us. So I think here you would do IgM. If it's negative, I wonder you would do IgG or not. I don't know the answer to that, but that's a great question.
I'm trying to remember this question from studying. And I think it was if the IgM is more reliable for like an acute infection as well, versus the IgG, which, you know, you can't differentiate if she was exposed now versus
years ago, yeah. But that's a great question. I will look it up. Okay, so wanted to mention just a few things that are sort of high yield for the rest of these viruses. So herpes virus we deal with pretty frequently. HSV1 is thought more to cause oral lesions. HSV2 is thought to cause more genital lesions. Once you have herpes virus, they live in your nervous system and they cannot be eradicated. And so you can use different antiviral therapies for reducing flares. COVID I won't mention much. We've worked with it a lot lately. West Nile virus is a mosquito-borne illness similar to dengue, although West Nile virus is seen in the United States, and so it's something that we see. Normally, the months for West Nile are June through October, so it's thought to be like a summer-fall illness, so you wouldn't see it in the winter. And then West Nile virus, you know, can cause encephalopathy, headaches, fevers are sort of the most common presentation there. Hep C we work with quite often, and one of the prominent causes of cirrhosis in our patients, and then Zika we just discussed. So why am I talking about this at all? And that's because really since I've been in med school and now residency, I've seen 2 epidemics, now a pandemic, Ebola, Zika, COVID, right? And I think that we would be remiss to think that we're gonna cruise through our internal medicine career without seeing more of these. The reasons for why pandemics, epidemics are increasing are because we're encroaching on the natural habitats of many of these vectors. There's exotic pet trade, there's exotic tourism, all of these things bring us much closer to these vectors than ever before. There are wet markets where these animals from different continents often are brought together, and so even more risk for highly contagious / highly resistant viruses to develop. And then finally, of course, there's worsening global weather trends. Calling it global warming, I think, is foolish now, given what's happening in Texas, right? So it's just this volatile weather that we're seeing everywhere across the world that also brings animal out of their natural habitats and closer to humans and causing more transmission across species. So that's why I just wanted to point out that we should be thinking more deeply about viruses than we ever have before. Okay, last one. Which one of these is not like the other? Yeah. Anita has 4. Anita, tell us why you think it's that.
Just like the mechanism is different.
The mechanism is different. Okay. Anyone want to expand upon that?
Not immune mediated.
Yeah.
not immune mediated. It
Or like involving.
can be immune mediated.
Or immediated. Cause like CSGM involves complement and then cryo is, who knows what that is. And there's the ANCA and then there's an antibody against TBM.
One can argue anytime you see itis, that's an immune mediated process, right? Maybe you mean not autoimmune mediated.
Sure. I think it's probably more glomerulus versus, like a nephritis. So, like, N says like interstitium process versus everything else here is a glomerulus problem.
Nightshade, yes, that's right, super close. I think a nephritis technically is still a glomerulus process, how we think about it in internal medicine. And I think what you were going for in the latter half of your explanation was that 4 of these are a glomerulus process. One of these, correctly, you guys identified number 4, is a tubular process. And so it's important for us to understand why that matters on knowing what is glomerulus versus tubular and how that's going to appear clinically in our patients. And so let's talk a little bit about this anatomy, and I'll try and simplify it in a way that helps us understand why I'm talking about this today. So as you remember, in a nephron, there are vessels that bring blood in and out. The first place that this blood is going to go is into the glomerulus, which is surrounded by Bowman's capsule. And then that's where urine crosses across and enters the tubules. And then it goes through all the concentration, dilution process, ultimately out into the kidney, or into the ureters, into the bladder. Okay, so glomerulus versus tubules. So when we zoom in on a glomerulus, you have these giant conglomerate of blood vessels, you have mesangial cells in there, and then you have this barrier between the glomerulus and the urine area, right? And this barrier has fenestrations, which can allow appropriate molecules to go into the urine, but will not allow some other molecules like a red blood cell or proteins to go into the urine. So let's zoom in even more on this barrier. And so when we zoom in there, what we see is that this is a capillary lumen, that's where all your blood is. The capillary itself has an endothelium or a wall. Then the glomerulus itself has a basement membrane, which is another barrier. And then finally, we have these podocytes, which foot processes are a third barrier. And these are what have the actual fenestrations or filtration slits through which fluid and other molecules can traverse. So just for an example, our red blood cells are too big to traverse through any of these holes, and so on a normal person who has all 3 layers intact, you should have no hematuria, right? At least from the glomerulus, you should have no hematuria. But albumin, for example, is small enough that it can easily traverse through all of these holes and end up in the urine. So why doesn't it? And that's because albumin is a negatively charged protein. These layers are largely negatively charged as well, so they repel albumin, and that's why albumin remains in the blood and doesn't usually spill into the urine. So that's why in a normal person that has all 3 barriers intact and all that negative charge intact, they're not going to have proteinuria because albumin won't be spilling into the blood. Does that make sense? So it's important to understand what these layers are and how they're affected in different diseases. So now that we talked about, right, anti-GBM disease tells us that that glomerular basement membrane is where the antibodies are targeted against. That layer will be damaged, and so you get protein spilling in the blood. Same kind of lining appears in our alveoli as well, and that's why in Goodpasture syndrome or anti-GBM disease, patients present with both hemoptysis and hematuria. And the reason is because that specific type of layer is what's damaged. Microscopic polyangiitis causes capillary endothelial damage. That's a vasculitis, right? And so this layer is damaged, and you get protein and blood spilled into the urine. So that's why then when you think about glomerular diseases, you really have to think about one of these layers is getting damaged, and now not only is protein spilling into the blood, so red blood cells. And so often in nephritic conditions, you're gonna see those red blood cell casts because red blood cells are now falling into the urine and then going through the tubules, which gives it that casty appearance. As opposed to something like a tubular disease, which NSAID-induced or other medications or infection-induced acute interstitial nephritis falls into, this like tubular process, you're not usually gonna see red blood cells in those patients, and certainly not red blood cell casts because not enough blood will go into the urine. What you normally see are, this is still an inflammatory process, and so you'll see white blood cell casts, and white blood cell, pyuria in the urine. Okay, so I really love this image, which helps me sort of put all the different AKI conditions in perspective. And as you can see, acute tubular necrosis and acute interstitial nephritis are both conditions of the tubule and not the glomerulus. And so when you're thinking about AKI, just think about what diseases are located in the glomerulus and what's going to cause spilling of both blood. And then in our specific nephrotic syndromes, why you get so much proteinuria, barriers are broken, and essentially your blood is interfacing with your urine, and so all of those proteins, like albumin, are spilling in the blood, causing that 3.5 grams per day amount of proteinuria. Okay, so if you understand that sort of concept, this question will become easier to answer.
Probably do A,
Probably do A. Tell me why.
because I'm worried he has ATN.
You're worried he has ATN, and if you're planning on doing A, or at least helping, or at least asking our nephrology colleagues to help us do urine microscopy, what are you gonna be looking for if you think that he has ATN?
Sorry, looking for granular cast.
Granular cast, awesome. Okay, so good, so that's the correct answer. Let's just go through why some of these other ones are incorrect. Why is FeNA incorrect in this patient? From the Lasix, yes, correct. So patients on diuretics will have an abnormal FeNA always, and so if you really care to do some kind of excretion evaluation, do an essuria. Remember that FeNA can also be less than 1% in patients with contrast-induced nephropathy, and so you're not really going to be able to tell whether it's tubular or prerenal in that case. Kidney ultrasonography is incorrect here because the patient already has a catheter in place, and so the likelihood that he's post-obstructed is pretty low. And then measurement of central venous pressure to make decisions is really not something we should be doing day to day anyway. And cardiology can help with that, but we know that those measurements, unless you have like a swan floating, are really difficult to interpret. So not the right answer there, plus we know he's already hypotensive. So good, so you're gonna look at the urine sediment to look for granular cast. And so now that we think about tubular diseases differently than we do our glomerular diseases, these tubular diseases have casts, and they cannot be comprised of red blood cells, okay? So these granular casts, what are they? Granular casts are basically like a jumble of tubular epithelial cells and different proteins that have already been excreted into the urine. And so when these proteins and mucoid tissue from the inflammation, from the necrosis, and the epithelial cells get together, they form these granular casts that then travel through the rest of the tubules, all this stuff travels through the tubules, which is what gives it that casty appearance. So just to boil this down into sort of a big summary that of course won't be 100% right all the time, but if you see red blood cell casts, or significant amount of hematuria in the urine, think glomerular disease. And then if you're seeing more non-bloody urine stuff, pyuria, think more tubular disease. What questions do you have about that? Do you guys have any questions in general about any of these conditions?
I think there's one thing that's interesting is MPA and the other ANCA-associated vasculitis are not complement mediated, which is what makes them posse immune. So like when we're talking about differentiating them, like that's one other thing that we can use as well.
Jake is teaching us that MPA, so GPA and ETPA are posse immune because they're not complement mediated. Great, thank you. Dr. Happy told us that cryo is complement mediated. Great. We talked about anti-GBM, look for patients that also have hemoptysis. And then PSGN, post-strep glomerulonephritis, usually occurs 2 weeks after a pharyngeal or skin infection with strep. And that's obviously a glomerular disease, so you'll see blood in the urine. Cool. Okay, so that's all I had. I want you guys to be the kind of doctors that stand out. So think about when you do type 2 thinking, and then especially when something in a patient's picture doesn't fit the rest of their picture, that's going to be a big clue to a diagnosis that you're missing or aren't thinking about. And that's all I have today.
Like that stock photo.